So thank you for allowing me to present today. So I'm going to discuss, or the title of my talk is Breathe Out, Finding Possibility. Many of you know about my work with the 2020 initiative, and I appreciate all of you participating in that endeavor. This actually harkens back to some research that I started when I first came here 5 years ago. So I'm excited to bring this to you because it actually all comes full circle, so hopefully this will make sense. So I have no financial disclosures. And here are my objectives for you. So it's really great that Merite had us strap in our seatbelts because I'm actually going to throw you into a really negative place right now. So we're going to review characteristics of difficult patients and how these patients impact healthcare providers. We will attempt to consider what might be missing in these interactions and ultimately propose steps for improving these relationships. And I'll introduce you to something called Breathe Out, so hence the title. So I will try to get us back to where Merite left us, so bear with me here. So here's a question I have for you. Who has been getting this email? Have any of you seen this? I've gotten this like 3 times in the past few weeks. So this is from Conflict Solutions, and there's a talk dealing with difficult patients, strategies, tips, and techniques for fighting frustration in the workplace. And it's happening next month, so you can still sign up for this. And they're going to talk to participants about the know-it-alls, the passives, the dictators, the gripers, the yes, and the no people. So I wanted to clarify that this is not what I'm going to talk about today. And I'm hoping I'm not dealing with anybody. And to be honest, I'm not sure I really believe that there are difficult patients out there. And so I have used the term difficult patients over the years in part to be provocative. And in fact, it is so provocative that unfortunately I have become known around campus as the doctor who talks about difficult patients. And so I was actually very flattered when David asked me to talk about my breathe out work, which is kind of rather how I'd be known. So anyway, if I take out dealing, I take off difficult, I'm left with people, and maybe that's what I'm going to talk about today. So in the spirit of the theme of the day about wellness, I'll just remind us a few definitions of wellness. So the World Health Organization will state that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The CDC says there's no sole determinant of individual well-being, but in general, well-being is dependent upon good health, positive social relationships, and availability and access to basic resources. And here's the National Wellness Institute, which describes wellness as a conscious, self-directed, and evolving process of achieving full potential. So I would propose that perhaps to consider this definition, that wellness is a dynamic process of change and growth and depends on our interconnectedness with the world. So I believe fundamentally at the heart of what we do as healthcare providers is that we are trying to grapple with issues of relationships, and to explore this really fully really has to do much with our sense of health and wellness. So it hopefully will be interesting for you today to explore relationships through the lens of our most challenging interactions. So I'm a Wellesley alum, and I always thought if I ever became an academic, I should show great art. So here we go. This is a painting from 1788 by Jean Germain Drouet. So although the painting is from the Renaissance, you can see it's depicting a subject from a much more ancient time. So anyone know who this is? This is Philoctetes. So he actually is depicted in a play by Sophocles from 409 BC. And some might argue he is one of the original depictions of a difficult patient. And so he is a soldier who's trying to get to the Trojan Wars, and he steps on a snake. And many doctors wonder that what he ends up with is probably chronic osteomyelitis of his foot. So he has this festering foot wound. and becomes the reviled patient, the chronic pain patient, to the point that he gets banished to the island of Lemnos. And in fact, Cornell University has been studying this play in their Theater of War project and looking at issues of chronic pain and PTSD. So difficult patients go back to ancient times. And one would argue they've evolved, certainly to modern times, and in the spirit of the holiday season, are they not like Dementors, right? So if anyone is a Harry Potter fan, you will remember that Dementors suck our souls out of us, and they take all the happiness out from the places they inhabit. So difficult patients have certainly propagated over the centuries, and they are here with us today. And so here are some alarming numbers. So the prevalence, unfortunately, is very high. So there's some studies that show that 1 in 6 or 15% of our ambulatory encounters are unfortunately with patients that we would consider difficult. And this is a really alarming number, that physicians who believe they have a high number of difficult patients are 12 times more likely to experience burnout. So what are characteristics of difficult patients? For those of you who are clinicians, anyone want to shout out a few things, what you think? Angry, okay.
Lack of insight.
Mm-hmm.
Lack of a sense of personal responsibility.
Yep. Greta?
People that complain that my chart is constantly timing them out when they're writing their message.
Oh, yes. I have some of those difficult patients. Mark.
Misplaced and unconditional faith in certain drugs to the exclusion of everything else.
We could obviously come up with a really long list here. Here's my list. So studies have shown they tend, and so in all these descriptions you're describing, they're all here. So mental health disorders, right? Multiple symptoms, they tend to come to us with at least 5 symptoms. Chronic pain, kind of like phylactetes. Poor functional status. Unmet expectations. They're never satisfied, but they keep coming back to see us. They're some of our highest utilizers in the healthcare system. Something else to consider is, what about us? So which clinicians have difficult patients? So this has been studied. So you should know that clinicians with poor psychosocial scores are more likely to find that they have difficult patients. Women, younger clinicians, and less experience in clinical practice. And this is a very alarming statistic. 9 versus 12 years makes a statistically significant difference. In other words, you need at least 10 years of practice to feel comfortable working with difficult patients. So let me just sort of briefly say how I got into this. It may be related to this peculiar skill set that I have. When I was a resident at the University of Washington, it became kind of renowned that I have this amazing capacity to make all my patients cry. So give me 10 minutes with any one of you, I could have you a puddle on the floor. And when I started teaching, I realized I have the same capacity with my clinical learners. And I would have residents weeping with me at the end of a really tough clinic day. And this was happening when I was doing some volunteer precepting at the University of Washington and shortly after coming here to University of Wisconsin. And it was never about a major medical error. It was never about the relentless in-basket. It was always around difficult patients. So some of you know that in my former life, I worked in a community health clinic in Tacoma, Washington. I was taking care of not only the uninsured and underserved, I was taking care of, I think, many a times, the unwanted and the unloved. And my clinic was within a few miles of Fort Lewis Army Base, which in 2010 was declared the most dysfunctional Army base in the United States. I was within a mile of a Western Washington State mental health facility. McNeil Island, the men's state penitentiary, was just off in the Puget Sound. We had the highest number of sex offenders in the state. And when I was practicing in South Tacoma, we were the meth capital of the I-5 corridor. So I know difficult patients, but I love that old job. And so my question in coming here was, well, how could I help my learners with these really challenging patients? So I thought the right thing to do is to look at the literature. So I found this fabulous article by Nancy Elder. She's at University of Cincinnati. And she and her colleagues interviewed 102 very talented physicians around the country. And they had to meet the following criteria. They had to be up to date, highly competent. They had to love their job. They had to be beloved by their learners. And they had to have at least 10 years of experience. And so she and her colleagues in this qualitative study came up with the following conclusions. So we should be avoiding opposition, misuse of power, and compassion fatigue. We should be attaining collaboration, appropriate use of power, and empathy. So that sounds really great, but it wasn't clear to me still, well, how do you actually do that, though? So let's consider the following. Let's think about them, those difficult patients. So I'm going to remind you that there are studies that show that strong patient-centered relationships promote greater satisfaction for both patients and providers. The physician belief scale measures clinicians' psychosocial orientation and correlates with a more patient-centered communication style. And so physicians who actually have poorer scores on the physician belief scale are more likely to have difficult patient encounters. Here's another study. This comes from as recent as 2008, which is a little alarming for all our attempts to move to a more biopsychosocial model. In a survey of 500 medical students and residents, 30 to 40% believe that addressing psychosocial factors led to minimal or no improvement in outcomes. So the other thing that was an interesting observation for me when I moved here in 2010 was the electronic health record here itself, as I'm learning the EPIC system here. So I, in acquiring a whole batch of patients at the Northeast Clinic, of which there are many difficult patients there, was really astounded to find that my problem lists were really beautifully maintained. They may not have had patient goals, but otherwise were beautifully maintained and had all this rich information in them. And then I would go to the section that those of you who are clinicians should know about called social documentation. Does anyone ever go there? So, yes, very good. So, social documentation to me is the most exciting part of the chart because this is where you can just free text whatever you want to. And it was invariably blank, actually. And so I actually queried the database and asked, well, what % of the time is it populated with anything at all? It could have been like the number one would have fulfilled the criteria. It was populated 27% of the time. So it begs to me the question as I contemplate all this, could we not better explore who they are? And then if we turn the mirror to ourselves, let's consider who we are. And I'll give you this quote from Anais Nin, the famous feminist of the early 20th century. She says the following: we don't see things as they are, we see things as we are. And here's a sort of visual metaphor for you. It says that we are holding the camera. That's how we are looking at things. And I'd just like to share a few thoughts about mindfulness. So this comes from Ron Epstein, who is one of our gurus of mindfulness at the University of Rochester, and he states the following. So I'll try to read this slowly for us. Mindfulness includes attending to the ordinary, the obvious, and the present. It includes an ability to observe the observed while observing the observer. Curiosity is central both to caring about the patient and solving their problems. A state of could be, welcoming uncertainty rather than trying to avoid it is also a very important component of mindfulness. And he goes on to say that perhaps lack of self-awareness is why physicians more often espouse these values of empathy, compassion, and altruism than demonstrate them, and why they tend to be less patient-centered and confuse their own perspectives with those of the patient. So the question is, could we also not better explore who we are? And in fact, what turned out for me to be the most fascinating part of Nancy Elder's article was not actually its conclusion, but what was kind of buried in the middle of what those very talented 102 doctors actually said. So they mentioned psyching up by checking their own attitudes and recognizing their own biases, as well as trying to separate their own emotions from those of the patient, remaining open to surprise, and even using breathing exercises. So Breathe Out was an instrument that I developed to assist clinicians with their most challenging patients and focused on an intentional exploration and reflection of bias, agenda, so the clinician's agenda, but also the patient's agenda, context, in other words, social history, incorporates a component of mindful breathing, and also hopes to encourage a place of openness to surprise or even vulnerability. And so you actually have, I see in your folder, this is a sort of abbreviated version of the tool. So Breathe Out, you can see, is actually a mnemonic. So that card, there's a little business card right on the inside there, and if you flip it over, it actually has the tool for you. And I just want to respect that there are some people who are not perhaps physicians. So I wanted to discuss a little bit more of the sort of philosophy and premise behind it, and someday I can give you more of a research talk. But basically, it's a set of questions or activities to do before seeing a challenging patient, and then rather than running off and seeing another patient, it actually requires a moment of reflection after that encounter. And just to say very briefly that a few years ago, we actually did a randomized control trial testing this tool across 6 family medicine residency clinics across the state. And I thank those of you who are sitting here who may have been participants in this. So in a nutshell, we applied something called a physician satisfaction survey, which is a validated tool where clinicians who encountered their most challenging patients would then sort of rate their satisfaction with that encounter. So for the intervention groups who had the tool, the Breathe Out tool, there was statistically significant improvement in patients and clinician satisfaction with these encounters. And what was more surprising to me was that it actually helped everyone. So not only did it help residents and the least experienced providers, but it also seemed to help even seasoned faculty members who'd had over 10 years of experience. So it's worth considering. And so I'll just go over it very quickly. Breathe, which is what is the activities to do before entering the room, would include, B is reflecting upon bias. So just so you know, people were not even writing full sentences in this. This whole activity probably took all of about 60 seconds to do. Bias is actually very complicated, and for those of you who are interested in really exploring implicit or unconscious bias, we're actually holding a whole afternoon workshop on this on November 20th, so I certainly invite you to participate in that. But people would write things like, patient's going to ask me for more narcotics or something like that. Reflect, RE is reflect upon why we consider this patient difficult. Why are we labeling them as such? Agenda, so A is agenda. Can we actually name what we want to accomplish today? So sometimes we're so eager to get this experience over with, we don't even think this intentionally about before going in. TH was think about collecting social history, and E was enter. So before entering, this tool is asking that we do a moment of breathing before running into the room. The out questions are what you do when you go out. So O is outcome. Can you actually state what the patient's agenda is? And this was actually very fascinating. People would start off saying, the patient is here because they're going to ask me for more opioids. And then when they write down what was their agenda, they would write something like, they're here to talk about their shoulder pain. It just had, it was much more diffused when they would write that answer. Did you accomplish your agenda? If not, how do you feel about it? And this was very interesting. Actually, many people were able to accomplish their agenda. And those who didn't were able to sort of, would say things like, but I better understood the context, so they felt more okay about not accomplishing their agenda. U was unexpected or is unexpected? Did you learn anything unexpected? And people wrote fabulous things here. Oh, I learned that he's a recording artist. You know, I learned this is a grandmother who knits. And you start to realize this language of difficult patient is starting to move away. These are like real people who you can think about in a totally different way. And T is tomorrow. What would you look forward to addressing the next time? People were not generally writing things like, I really look forward to addressing their hypertension, right? They would write things like, I wonder how their train trip went. My favorite was, is it a boy or is it a girl? So that is what people were writing in this form. And ultimately, this is what I'm trying to get at. So I was thinking about the Navi people the other day. So who are the Navi people? Who said that? Yes, Justin. Very good. It is the blue people in outer space of Avatar. And what do they say as their greeting, Justin? I see you. And to me, I'm not a great fan of Avatar, but I fell in love with the Navi people. And I just feel like, I don't know if we can greet people and say, I see you, but if we could end all of our clinic visits and grab someone's hand and look them in the eye and say, I see you, I mean, would that not be profound? So ultimately, I have always felt that possibility lies in the face-to-face encounter. It is where there's the most opportunity for unexpected things to occur and for us to grow, as well as our relationships with patients to grow. And I'm not sure I really believe that as we collect narratives from patients, it's not such a discrete thing that it's one person sitting across from me and I'm here and it's an exchange of information. There's something in the milieu of the in-between where rich possibility lies. And if we can keep sort of the framework of the breathe out tool in that middle space, I feel like 1 + 1 has, who knows, infinite possibilities. So through an openness to, I'll say metaphorically embracing authentically the other, and considering the self, the face-to-face encounter offers potential for the new and unexpected, and it is here that we can find hope. So thank you.